Now we are going to discuss upper GI bleeding. Upper GI bleeding. So question is asked, what's the most common cause of upper GI bleeding? The most common cause of upper GI bleeding is non-varicose, and overall most common cause is peptic ulcer. So first question, the most common cause of upper GI bleeding is the peptic ulcer. Generally in peptic ulcer, be careful, there is massive bleeding, and because of this massive bleeding there is hematemesis. So second question, what is the first investigation done in upper GI bleeding? So first investigation done in upper GI bleeding, and that is endoscopy. It's the upper GI endoscopy. After that, nowadays lots of questions are asked about risk stratification strategies in upper GI bleeding. So what are those risk stratification strategies? One is Roccal-Baylor score and second is Blatchford score. So have a look. Risk stratification strategies or systems in upper GI bleeding. What is the use of this risk stratification system? This is used to predict the risk of rebleeding and mortality in patients of upper GI bleeding. So this is used to identify the patient at risk of major bleeding, or death based on the patient findings. So this is basically used for patients' triage. The commonly used scoring systems are, first is the Roccal-Baylor score, and the second is Blatchford score. Is the Blatchford score. First question is asked, out of these two, which one is most useful? The Roccal-Baylor score is based on endoscopic finding, and that's why it's most useful. So this one is most useful. Why? Because it is based on endoscopic findings. Now, why this Blatchford score is not very useful? Because in this endoscopic findings are not included. So this one is used during initial assessment. It is used during initial assessment of patient. And here endoscopic findings are not included, or endoscopic data, it's not included. Lots of questions are asked about this Blatchford score and Roccal and Baylor score. The questions are asked about what are the components of Roccal and Baylor score and Blatchford score. So have a look. We are going to discuss one by one. First of all, Blatchford score. Blatchford score. What are the components? First, pulse. Second, blood urea nitrogen. Third, systolic blood pressure. And fourth, hemoglobin. Pulse, blood urea nitrogen, systolic blood pressure, and hemoglobin, with presence of other parameters are presence of melena, syncope, cardiac or hepatic dysfunction, hepatic, cardiac or hepatic dysfunction. Now how to remember? It's very easy to remember. Have a look. This is push. So what? Push plus melena syncope. Push plus melena syncope plus cardiac or hepatic dysfunction. Cardiac or hepatic dysfunction. So this is how you can easily remember. Push plus melena syncope plus cardiac or hepatic dysfunction. So these are the components of Blatchford score. Now see Rokal and Baylor score. Rokal and Baylor score. I told you that it is more useful and it includes the endoscopic findings. Now see the components. First, comorbid disease. Comorbid disease. Second is age. Third is shock. In shock, if the systolic blood pressure is less than 100 mmHg or pulse rate is more than 100 per minute. Diagnosis at the time of endoscopy. Diagnosis at the time of endoscopy and endoscopic stigmata of recent bleed. Endoscopic stigmata of recent bleed. So these are the components of Rokal and Baylor score. How to remember? The mnemonic is CAS-D. The mnemonic is CAS-D. So you can make out it's the CAS-D. C. Comorbid disease. A. Age. S. Shock. D. Diagnosis at the time of endoscopy. And E. Endoscopic stigmata of recent bleed. So these are the two commonly used risk stratification strategies for upper GI bleeding. Third important classification is bleed risk classification. So this is very important. Bleed risk classification. So again, the uses of this bleed risk classification is almost similar. What? It is used to predict. It is used to predict the risk of rebleeding, and mortality. So it is used to predict the risk of rebleeding and mortality in patients of upper GI bleeding. Now see, it is based on following criteria. There are total 5 criteria. Can you see? Bleed. So there are 5 criteria. First, ongoing bleeding. It's ongoing bleeding. Second, low systolic blood pressure. Third is elevated prothrombin time. Elevated prothrombin time. So it should be how much? More than 1.2 times of control value. Fourth, erratic mental status. Erratic mental status. And fifth is unstable comorbid disease. Unstable comorbid disease. So what are the 5 parameters? You can see this is bleed. So ongoing bleeding, low systolic blood pressure, elevated prothrombin time, more than 1.2 times of control value, erratic mental status, unstable comorbid disease. So in exam, these 3 are commonly asked. One is Rokal-Baylor, second is Blatchford score, and third is bleed risk classification. After that, see, I told you the first investigation done in patients of upper GI endoscopy. I told you the first investigation done in upper GI bleeding is endoscopy. Now, on the basis of endoscopic findings, we can predict that what are the chances of rebleeding. And this is predicted by a classification known as Forest classification. So have a look. What's the Forest classification? Forest classification. It is based on endoscopic findings. It is based on endoscopic findings to predict rebleeding risk. To predict rebleeding risk. Now see what are the types and what are the chances of rebleeding. First, 1A, the category 1A. In this, there is active pulsatile bleeding. Active pulsatile bleeding. After that, there is 1B. In 1B, there is only oozing. 2A. 2A is non-bleeding visible vessel. Is the non-bleeding visible vessel. 2B. It's the adherent clot. Adherent clot. 2C is the black dot. 2C is the black dot. And 3 is the clean base. 3 is the clean base. Now see in which cases there is high risk of rebleeding. You can see in 1A, 1B, 2A, here there is high risk of rebleeding. After that in 2B there is intermediate risk of rebleeding, and there is low risk. There is low risk of rebleeding in 2C and 3. So these are classification systems which are very, very important. After that, what are the bleeding disorders of stomach? One is Mallory-Weiss syndrome, second is Diel-Foys lesion, and third is watermelon stomach. Since these are bleeding disorders of stomach, so obviously there will be bleeding, and if there is bleeding, what's the investigation of choice in all these three conditions? I'm repeating, in Mallory-Weiss syndrome, in watermelon stomach, and in Diel-Foys lesion. Since there is bleeding, so in all the three conditions one thing is common. What? That investigation of choice is same, and that's what upper GI endoscopy. Second, the management is also almost similar. In all the three, usually we go for endoscopic electrocoagulation, and if it's not controlled, if it's possible, we can go for angiography plus embolization, and if it's not available or failed, we can go for surgical ligation. So see, in detail we are going to discuss one by one. First, Mallory-Weiss syndrome. So here you can see what is the Mallory-Weiss syndrome. Here there is partial tear, can you see? And this partial tear is located at cardia. The most common site is cardia, and this is located just below G junction. Since it's partial tear, it is only involving mucosa and submucosa. Bleeding is minor in majority of cases, and generally it's a painless condition. Now see, in which case there is Mallory-Weiss syndrome. In which case Mallory-Weiss syndrome is going to occur. Generally these patients are having repeated vomiting or forceful vomiting. Because of that, there is too much of pressure in the stomach, and that's why there is partial tear at cardia. So one by one we are going to discuss. First, see the important points of this Mallory-Weiss syndrome. So first question is the longitudinal tear. You can see is the longitudinal tear in stomach. Be careful, in esophagus we discussed longitudinal tear in esophagus is the Boerhaave syndrome, and that is complete tear. This is partial tear. So it's the longitudinal tear in stomach. First question. Second, what's the most common site? Is the cardia, or it's located just below GE junction. Be careful. Just below GE junction is the partial tear. So it involves only mucosa plus submucosa. Only mucosa plus submucosa. What are the risk factors? Risk factors are repeated vomiting. Is the repeated vomiting or forceful vomiting? Repeated vomiting, forceful vomiting, and retching. And you must be knowing that all these are very common in alcoholics and in males. So generally it is more common in alcoholics and in males. Now coming to the clinical features. It's partial tear. In most of the cases there is minor bleeding. There is minor bleeding in majority. So question is asked, in how many cases there is massive bleeding? So in 20% cases there is massive bleeding, and it's painless condition. It's painless condition. Okay. After that there was one question, that which artery is responsible for bleeding in Mallory-V syndrome? And you can easily crack this question on the basis of anatomy. Just have a look. If you see this area, you can see that this cardia is supplied by which artery? See the diagram? If you see, this is the stomach. Okay, this is the cardia. This region is supplied by which artery? So you can easily predict that this is what? Left gastric artery. So the cardia is supplied by left gastric artery. So most common artery responsible for bleeding in Mallory-V syndrome, left gastric artery. Second question, there is another question in anatomy. What's the largest vessel supplying stomach? It's the left gastric artery. So two questions. First, what's the most common vessel responsible for bleeding? Responsible for bleeding in Mallory-V syndrome, and it's the left gastric artery. And another question which is asked in anatomy, that is the largest vessel supplying stomach. Largest vessel supplying stomach. Okay. I discussed before that generally in cases of bleeding disorders of stomach, what is the investigation of choice for diagnosis? Endoscopy. So here also, diagnosis, investigation of choice for diagnosis is the endoscopy. I told you, in majority of cases the bleeding is minor. That's why conservative management is sufficient. Second is the partial tear and painless condition. So conservative management is sufficient. So what's the management? In majority of cases, conservative management is sufficient. But I told you that in 20% cases there is massive bleeding, and if there is massive bleeding we have to control the bleeding. So for non-responding patients, what we have to go for? We go for endoscopy plus electrocoagulation. Electrocoagulation of bleeding vessel. If it's not available or failed, in that case, we go for angiography plus embolization. And suppose this is also not available, this is not available or failed, this is also not available or failed. In this case also, if it's not available or failed, in this case we go for open surgical ligation. Open surgical ligation. So this is how we manage the Mallory-V syndrome. One common question is asked. We discussed in patients of portal hypertension, there is variceal bleeding. And in variceal bleeding, when the patient is being transported from PHC to higher center, we were using one tube, Sengstaken-Blakemore tube. So can we use Sengstaken-Blakemore tube in Mallory-V syndrome? No, because it's contraindicated. Why? See, in variceal bleeding, the bleeding is venous. In Mallory-V syndrome, it's arterial. Second, the more pressure is required to control the bleeding and more you inflate the balloon, what will happen? The partial tear will be converted into complete tear. So here, Sengstaken-Blakemore tube is contraindicated. Sengstaken-Blakemore tube, it's contraindicated. Now see this condition. Here you can see just beneath the mucosa there is presence of the arteriole. And can you see what kind of bleeding? Can you see here? There is active pulsatile bleeding. This is known as what? Diel-Foys lesion. So what's the name of this condition? This is known as Diel-Foys lesion. So what happens in Diel-Foys lesion? It is characterized by presence of large arteriole. You can see there is presence of large arteriole. Question is asked, how much is the diameter? It's 1 to 3 mm. First question, what is the location? It is located within 6 to 10 centimeter of GE junction near lesser curvature. And where is the location? Exact location placed just below mucosa. It is placed just below mucosa. Clear? Now see the problem. What happens in Diel-Foys lesion? See, this is the stomach. Within 6 to 10 centimeter of GE junction, there is presence of a large arteriole. How much is the diameter? 1 to 3 mm. Now what is the problem? Now see the problem. Suppose this is the mucosa and just beneath mucosa there is presence of arteriole. This is a large arteriole and you must be knowing that arterioles are having pulsation. So because of this pulsation, what will happen? This arteriole is going to pulsate. So can you see? Because of this pulsation, can you see? Overlying mucosa will be necrosed because of this pulsation and this arteriole will be exposed to the gastric environment, acidic environment of stomach. And since there is acidic environment, this is arteriole, not the artery, so its wall is thin as compared to artery. Over its thin wall there is action of acid and the wall is injured, and because of this this is going to occur. Can you see what kind of bleeding? There is active pulsatile bleeding. And I told you, according to Forest classification, active pulsatile bleeding is type 1A. And type 1A is having high risk of rebleeding. So same thing occurs here. It is associated with high risk of rebleeding. There is massive bleeding, and because of that, patient is having hematemesis and recurrent hypotension. So I'm repeating here. What? There is action of acid to exposed wall of arteriole, leading to injury of wall, and it leads to active pulsatile bleeding. Active pulsatile bleeding. Clear? Now, what is the presentation here? See the clinical features. So, in these cases, there is massive bleeding, and because of this massive bleeding, what is the problem? One, there is hematemesis. And second is there is recurrent hypotension. Recurrent hypotension. Why? Because it's 1A, so there is high risk of rebleeding. Question is asked, what's the investigation of choice for diagnosis? And I told you already, it's the endoscopy. How we are going to manage? Management, same. We go for first endoscopic electrocoagulation. If it's not available or failed, we go for angiography plus embolization. If it's not available or failed, last treatment option is what? Surgical ligation. Clear? So this is how we manage the Diel-Foys lesion. Third is watermelon stomach. Now you can see this is looking like rind or covering of watermelon when you remove that green color covering of watermelon, and this is known as what? Watermelon stomach. What's the other name of watermelon stomach? It is also known as GAVE. The other name is GAVE. Full form is the gastric antral vascular ectasia. Gastric antral vascular ectasia. So here you can make out the answers are hidden in this term GAVE. Question: what is the pathology? In watermelon stomach is the vascular ectasia. Second, what is the most common site? The most common site is antrum. And watermelon stomach, when we perform the endoscopy, you can see how it looks like. There is dilated vessels and it appears parallel. So there is parallel arrangement of dilated blood vessels near the antrum. It looks like watermelon covering or rind. That's why it's known as watermelon stomach. So see the questions. First question: what's the most common site? Antrum. Second question: what's the pathology? What's the pathology? Here there is vascular ectasia. Now see the clinical features. It is seen in elderly females. Seen in elderly females. And what's the problem here? Because of vascular ectasia, there is chronic occult bleeding. And if there is chronic occult bleeding, it leads to what? Anemia. And because of anemia, what is the symptom? Fatigue. So what? These are elderly females who are coming to you with fatigue or anemia. And 25% patients have chronic liver disease. They have chronic liver disease. Now how we are going to make the diagnosis? One, you should be having this kind of appearance on endoscopy. And second, there should be confirmation of pathological problem, what? Vascular ectasia. So Diagnosis. Investigation of choice for diagnosis is the endoscopy plus biopsy. Now see what you want to see on endoscopy. There is parallel arrangement of vessels, arrangement of dilated vessels near antrum. Okay, and on biopsy what you want to find out, that there is vascular ectasia. In this case there is vascular ectasia, so we are going to diagnose it. Now see how we are going to manage. It's easy. The treatment is generally endoscopy plus electrocoagulation. So this is how we manage. Let me tell you, this watermelon stomach, Diel-Foys lesion and Mallory-V syndrome, these three topics are asked in medicine, surgery and pathology, and almost every year you will get a question from these three topics. Now before discussing carcinoma stomach, I want to discuss certain important points. I told you that squamous cell carcinoma is generally more common in low socioeconomic status, and adenocarcinoma is generally more common in high socioeconomic status. Why? Because in low socioeconomic status there is low fat intake, there is poor sanitation, there is increased risk of HPV infection, and the food and water they take or consume, it's not very hygienic. Now coming to high socioeconomic status. In high socioeconomic status there is high intake of fat and there is low fiber intake. That's why adenocarcinoma is generally more common in high socioeconomic status. But see, carcinoma stomach is an exception. It is adenocarcinoma, but it's more common in low socioeconomic status. Why? Because people belonging to low socioeconomic status, they take food and water which is not hygienic, generally contaminated with H. pylori, and H. pylori is a risk factor for carcinoma stomach. So have one thing in your mind, that whenever you are remembering the risk factors of carcinoma stomach, just think that this malignancy is more common in low socio-economic status. So see, what are the risk factors? Risk factors for carcinoma stomach. First is nutritional. Now see, low fat diet. Low fat diet. High complex carbohydrate intake. And intake of nitrates. Okay, after that, social risk factors. It is more common in low socio-economic status. Low socio-economic status. After that, third, environmental. In environmental, first, lack of refrigeration. This question was asked in AIIMS. What was the question? Due to advancement in the technology of refrigeration, which of the following malignancy is decreasing exponentially? It's carcinoma stomach. So what is the relation? When we put food and water in refrigerator, what? H. pylori gets killed. Because for H. pylori, the best temperature is body temperature, and that is 37 degrees centigrade. So if there is lack of refrigeration, it will be a risk factor. Use of well water. Poor food preservation technique. poor food preservation technique. And what else? Smoking. All these increases the risk. After that, medical risk factors. What are the medical risk factors? First, obviously, which bacteria infection? H. pylori. H. pylori infection. Which virus infection is the Epstein-Barr virus infection? History of partial gastrectomy. Chronic atrophic gastritis is the chronic atrophic gastritis. Adenomatous polyp is the adenomatous polyp. And Menetrius disease. Menetrius disease. These are the medical risk factors. After that, fifth, occupational risk factors. This question was asked in a latest exam. Is the rubber and coal workers. Rubber and coal workers. And after that, genetic risk factors. Genetic risk factors. What are the genetic risk factors? First, male gender, blood group A, pernicious anemia, HNPCC, and Li-Fraumeni syndrome. Li-Fraumeni syndrome. So all these are the risk factors for carcinoma stomach. There is very important point. What? Alcohol is not the risk factor for carcinoma stomach. Be careful. Alcohol, it's not a risk factor. This is important point. Alcohol is not a risk factor for carcinoma stomach. After that, very important, what are the protective factors? Protective factors for carcinoma stomach. And mnemonic is CySac. CySac is protective. Full form: S. selenium, I. iron, Z. zinc, A. aspirin, and vitamin A, C. calcium, and vitamin C. So all these are protective factors for carcinoma stomach. There are two classification systems which are frequently asked in relation to carcinoma stomach. One is Borman's classification and second is Lawrence classification. Have a look. So first is Borman's classification. This Borman's classification, it is based on macroscopic appearance. It is based on macroscopic appearance and it is going to divide carcinoma stomach into 5 types. Type 1, 2, 3, 4 and 5. What's type 1? Is the diffuse polypoidal growth. Diffuse polypoidal growth. What is type 2? Is the ulcerated lesion with raised borders. Ulcerated lesion with raised borders. Type 3. Ulcerated lesion infiltrating the gastric wall. infiltrating the gastric wall. Type 4 is the Linitis plastica. This is Linitis plastica. And what's type 5? It's the non-classifiable. So if it's not classified in any 4, it becomes type 5. This is Borman's. But nowadays, more commonly asked classification is Lorentz classification. Lorentz classification. According to Lorentz classification, there are 2 types of carcinoma stomach. First is intestinal. Is the intestinal, and the second is diffuse. Now it's very easy to remember. See, the intestinal variety is the classical variety. Classical variety means the kind of carcinoma stomach you people know. Generally, you know that most common site of carcinoma stomach, distal part, it is more common in males and generally it is seen in elderly. So this is the classical type. What is the diffuse variety? It's atypical. Imagine carcinoma stomach arising in females who are young and the most common site is proximal part. So this is atypical. So how to remember it easily? Just remember this, that intestinal is the classical variety. Is the classical variety and the diffuse is atypical variety. So what are the differences? Have a look here. There are environmental risk factors, and here there are familial risk factors. Here it is more common in elderly. This one is more common in young patients. This one, it's more common in males, and this one, it's more common in females. Here, most common site is the distal part. Is the distal part, and here, most common site is the proximal part. In this case, there is well-defined gland formation. Well-defined gland formation. And here there is poor gland formation. And since there is poor gland formation, you will find signet ring variety here. So here there is signet ring variety. After that, in this case, there is hematogenous spread. Is the hematogenous spread. And here transmural or lymphatic spread. There is lymphatic spread. Now see, there are certain similarities also. Now see what are the similarities. Here in both there is inactivation of P53 and P16 inactivation. So it is seen in both. This is seen in both. In intestinal variety there is APC gene mutation. There is APC gene mutation, whereas in this case there is decreased E-cadherin. Decreased E-cadherin. This one is epidemic, means it is scattered, and this one is what? Endemic. So these are the differences between intestinal and diffuse variety. Now in detail we are going to discuss the carcinoma stomach. So first question, the maximum incidence of carcinoma stomach is seen in Japan. There is maximum incidence of carcinoma stomach It is seen in Japan. Second question, what's the most common site of carcinoma stomach? Most common site is antrum. Now see the second question. What is the most common site of carcinoma stomach in pernicious anemia? So second question, most common site in pernicious anemia. In pernicious anemia, and it's the fundus. So in pernicious anemia, it's the fundus. After that, what is the most common site of metastasis? The most common site of metastasis, that's liver. It's the liver. And the question is asked, what is the chemotherapy regimen for carcinoma stomach? And the chemotherapy regimen, it's same like esophagus. And I told you, in carcinoma esophagus and in carcinoma stomach, the regimen is what? ECF. It's the ECF, full form E. There is epirubicin, is the epirubicin. C is the cisplatin, and F, that's the 5-fluorouracil. So it's ECF, epirubicin, cisplatin, 5-fluorouracil. Now see what's going to happen in carcinoma stomach. Clinical features, you can see this is the stomach, and in majority of cases, where is the malignancy? It's located at antrum. And if there is growth at antrum, generally it causes obstruction. And because of that, what's the most common symptom? The most common symptom, it's abdominal pain. The most common symptom, it's abdominal pain, followed by weight loss. So the most common symptom is abdominal pain followed by weight loss. Now see, the symptoms will depend on the location of the tumor. Imagine that tumor is located here at GE junction. So if the tumor is located at GE junction, so for GE junction tumors, the most common symptom is dysphagia. For GE junction tumor, the most common symptom is the dysphagia. And you know, nowadays there is increase in incidence of GE junction tumors. That's why there is a specialized classification system for GE junction tumors, and that's known as Sievert classification. Have a look. So for this GE junction tumors, there is special classification, and that is Sievert classification. Now you can see this is what cardia, and this is obviously for adenocarcinoma. Now can you see what is this type 1? It extends from 1 centimeter till 5 centimeter of cardia, and it includes type 1. This includes adenocarcinoma of distal esophagus. And you can see what's the extent or location of this tumor, from 1 centimeter to 5 centimeter above cardia. Now can you see this is type 2, and this is the adenocarcinoma of real cardia. And what's the location? Yes, it's from 1 centimeter above cardia till 2 centimeter below cardia. So 1 centimeter above till 2 centimeter below cardia. This is the adenocarcinoma of real cardia. After that, see, this is type 3. And this type 3 is adenocarcinoma. It's the adenocarcinoma of subcardial stomach. And can you see the location? It's from 2 to 5 centimeter below cardia. So these are 3 types of Sievert classification. So now coming back to carcinoma stomach. In GE junction tumors, most common symptom is dysphagia. After that, there is a condition known as linitis plastica. So what is linitis plastica? See, so in linitis plastica, here you can see there is diffuse proliferation of fibrous tissue in submucosa, and because of this proliferation of fibrous tissue in submucosa, stomach loses the capacity of distensibility, and on investigations, can you see this barium meal? On investigation, it is looking like leather bottle, and that's why it's also known as leather bottle stomach. So other name of linitis plastica, it's the leather bottle stomach. What's the problem here? There is diffuse proliferation of fibrous tissue. Proliferation of fibrous tissue in submucosa. And if the patient is having this linitis plastica, what's the problem? Stomach loses the capacity of distensibility. So here the most common symptom, it's early satiety. It's the early satiety. So in linitis plastica, the most common symptom is early satiety. Now see, carcinoma stomach is having wings, means it can fly any place in the body. What is the meaning? Have a look. If it is involving left axilla node, it is known as Irish nodes. In carcinoma stomach, there is involvement of left axilla lymph node, Irish nodes. After that, in certain patients, there is involvement of this left supraclavicular lymph node. The name of this node is Virchow's node, and the name of this sign is Troisier sign. So it's the Virchow's node. Virchow's node. This is the involvement of left supraclavicular lymph node, and the sign is known as Troisier's sign. After that, there is cutaneous metastatic deposit around umbilicus, and that's known as Sister Mary Joseph node. It's Sister Mary Joseph node. So Sister Mary Joseph node, be careful, it's not a lymph node. It's the metastatic deposit around umbilicus. So this is cutaneous. It's the cutaneous metastatic deposit. Cutaneous metastatic deposit around umbilicus. So this is Sister Mary Joseph node. After that, there is Blummer's shelf. Blummer's shelf. What is this Blummer's shelf? This is palpable intraperitoneal metastasis on digital rectal examination. So this is the palpable intraperitoneal metastasis on digital rectal examination. This is Blummer's shelf, and you must be knowing that there is involvement of bilateral ovary in carcinoma stomach. And what's the name? It's Krukenberg tumor. There is Krukenberg tumor. Is the involvement of bilateral ovary in carcinoma stomach. Via these routes are asked. It can occur via hematogenous spread, via retrograde lymphatic spread, via transcoelomic transperitoneal spread. So there are three routes. First, retrograde is the retrograde lymphatic spread. Second is hematogenous spread, and third is transcoelomic, or transperitoneal spread. Transcoelomic or transperitoneal spread. Be careful, all these are the routes, but which one is the most common route is the retrograde lymphatic. This is a question. See, initially the most common route was transcoelomic or transperitoneal, but be careful, this is changed. So this is changed nowadays and it is retrograde lymphatic. What is anterograde and retrograde? See, anterograde means along the flow, retrograde means against the flow. So this is retrograde lymphatic spread, most common route for Krukenberg tumor. After that, how we are going to diagnose? So see, the diagnosis. Investigation of choice for diagnosis is the endoscopy plus biopsy. And in carcinoma esophagus, I told you, any malignancy where we can perform endoscopic ultrasound, generally that's the investigation of choice for staging. So investigation of choice for staging, especially early gastric cancer, especially the early gastric cancer, and that is endoscopic ultrasound. Now see the twist in the question. Best pre-operative investigation for staging, and that is CCT. Best pre-operative investigation for staging, and that is CCT. So these are the investigations used for staging and diagnosis. Now we are going to discuss the 8th AJCC TNM classification for carcinoma stomach. 8th AJCC TNM classification for carcinoma stomach. So it's easy to understand. See, first is the TIS. TIS means carcinoma in situ. Is the carcinoma in situ. That's TIS. After that, there is T1A. And in T1A, there is involvement of lamina propria, or muscularis mucosa. Involvement of lamina propria or muscularis mucosa. After that, T1B, which layer is located just below muscularis mucosa? Submucosa. So there is involvement of submucosa. After that, T2, which layer is located just below submucosa, is the muscularis propria. So there is involvement of muscularis propria. Now in T3, tumor penetrates subserosal connective tissue. So there is penetration of subserosal, be careful, subserosal connective tissue without invasion of visceral peritoneum or adjacent structures. Without, this is important, without invasion of visceral peritoneum or adjacent structures. Clear? So it's simple. Whatever the structures which are not involved in T3, generally these structures are involved in T4. So see, what is T4A? In T4A, there is involvement of visceral peritoneum. visceral peritoneum, obviously, or serosa. And what about T4B? T4B, there is involvement of adjacent structures. Involvement of adjacent structures. So this is simple. So this is T. After that, see the lymph node staging, N. First, what's the N1? Is the metastasis to to 1 to 2 regional lymph nodes. This is N1. What is N2? In N2, there is metastasis to, be careful, 3 to 6 regional lymph nodes. What's N3A? In N3A, there is metastasis to 7 to 15 regional lymph nodes. And what's N3B? In N3B, there is metastasis to 16 or more regional lymph node. Easiest is metastasis, distant metastasis. So M0, no metastasis, and M1, there is distant metastasis. So this is TNM classification. It's important and it's frequently asked in exam. Now coming to management of carcinoma stomach. Now see what principles we are going to follow in management of carcinoma stomach. See the first principle. Generally we take 5 cm proximal and 5 cm distal margin. Second, the lymph node levels in carcinoma stomach are divided into 16 stations 1 to 16, and it is further divided into 3 substations D1, D2, D3. So we are going to remove lymph node up to D2 substation. Now see how we are going to manage. It depends on the location of malignancy. So this is upper 1/3, this is middle 1/3, this is lower 1/3. Here is the malignancy. If malignancy is located in upper 1/3, we go for extended gastrectomy. Extended gastrectomy means we remove stomach plus distal part of esophagus. So here we go for extended gastrectomy. And apart from extended gastrectomy, we go for D2 lymphadenectomy. When the malignancy is located in the middle 1/3, we go for total gastrectomy plus D2 lymphadenectomy. And if it's located in distal 1/3, we go for subtotal gastrectomy plus D2 lymphadenectomy So this is the treatment which is applicable for both intestinal and diffuse, but there is one exception. In diffuse variety, especially involving this distal 1/3, at the place of subtotal gastrectomy, we go for what? Total gastrectomy. Rest of the treatment is same for intestinal and diffuse. So have a look. What's the exception here? For diffuse variety involving distal 1/3, we go for total gastrectomy. We go for total gastrectomy plus D2 lymphadenectomy plus D2 lymphadenectomy. This is one concept. Second concept, in which cases we have to go for splenectomy and distal pancreatectomy. Now see, it's easy to understand. This is the stomach, this is the duodenum, this is the pancreas, and this is the spleen. Suppose there is carcinoma stomach directly involving or infiltrating body or tail of pancreas. In those cases, we go for distal pancreatectomy. So first statement, what are the indications of distal pancreatectomy? And it's easy. There is involvement of body or tail, body or tail of pancreas. Simple. After that, what are the indications of splenectomy? One, there is direct involvement of spleen. Or second, there are high chances of involvement of spleen, and it's very easy to understand this concept. You can easily understand that this spleen is mainly in relation to which part of stomach? Is the proximal part, which curvature is the greater curvature, and which wall? Posterior wall. I'm repeating. Generally, spleen is in relation to stomach. Which part? Proximal part. Which wall? Posterior wall. Which curvature? Greater curvature. So if malignancy is arising from proximal part of stomach located along greater curvature or posterior wall, then we go for splenectomy. So statement, indications of splenectomy. Indications of splenectomy. First, direct involvement of spleen. There is direct involvement of spleen. And second, carcinoma stomach. Be careful. In, this is important, in which part? In proximal part. In proximal part, located along posterior wall or greater curvature. Posterior wall or greater curvature. So in these cases, we go for routine splenectomy. So this is how we are going to manage the carcinoma stomach. After that, I told you most common site of metastasis is liver. Question is asked, what are the prognostic factors? Generally, in GI malignancies, there are two important prognostic factors. First is the depth of invasion, and second is lymph node status. Question is asked, what's the most important prognostic factor? It's the stage. Stage include T and M. And if a single most important prognostic factor is asked, it's the lymph node status. So this is the single, be careful, is the single most important prognostic factor. So this is how we are going to manage the carcinoma stomach. Next is very important topic, that is GIST. GIST, what is the full form of GIST? It's the gastrointestinal stromal tumor. It's the gastrointestinal stromal tumor. Now how to remember this tumor? It's very easy. See, I told you that carcinomas are having epithelial origin and sarcomas are having what? Stromal or mesenchymal origin. So here you can make out that what kind of tumor is this? It is having stromal origin, means this tumor will behave like sarcoma. And if it will behave like sarcoma, sarcomas are having usually hematogenous spread. They don't have lymphatic spread. So in this tumor also, there will be only hematogenous spread. There won't be lymphatic spread. And if the tumor is arising from GIT having hematogenous spread, what's the most common site of metastasis? Yes, that is the liver. So here also the most common site of metastasis is liver. Since it behaves like sarcoma, in sarcomas we go for wide local excision. So here we go for segmental resection or wedge shaped excision. Generally, we are not going to perform lymphadenectomy because here there is no lymph node metastasis. So see the question. First, just what's the most common site? Most common site of GIST is the stomach, followed by small intestine, followed by colon, rectum, followed by esophagus. It arises from gastric pacemaker cell. That's the gastric pacemaker cell. And this gastric pacemaker cell, other name is interstitial cells of Kegel. Interstitial cells of Kegel. You know, this tumor is going to express tyrosine kinase receptor. Tyrosine kinase receptor. Be careful. Whatever I'm telling you about this tumor, each and every statement is having minimum one MCQ. So express tyrosine kinase receptor, and that's c-KIT. It express the marker. The marker is CD117. So this is the marker for this receptor. What are the other markers which are raised? Other markers for this tumor, there is CD34, there is BCL2, and there is PDGFR alpha. PDGFR alpha. So what's the full form? Is the platelet derived growth factor receptor alpha, PDGFR alpha. There are certain new markers, and these new markers are asked in exam. These new markers are asked in exam. First, DOG1. This is most important. Full form, it's detected on GIST1. And second is protein kinase C theta. It's the protein kinase C theta. These are the two new markers in which DOG1 is most commonly asked. After that, what are the types of GIST? It's of two types. First, spindle cell variety, and the second is epithelioid. Which one is more common? Spindle cell 70% and its epithelioid, which is 30%. So these are the types. After that, clinical features. Now see the difference. You saw that this was the carcinoma stomach. What was the growth? This kind of growth inside the lumen. And can you see the growth of GIST? This kind of growth is generally extraluminal extramural. It means in majority of patients, there is no symptoms. There are no symptoms in early stage. But see, the tumor is highly vascular. And since this tumor is highly vascular, sometimes it starts bleeding. So the presentation is abdominal pain or bleeding. So question, what's the most common symptom? So in this case, the most common symptom is the abdominal pain and bleeding. Abdominal pain and bleeding. Since it behaves like sarcoma, what's the most common route of spread? The most common route of spread is the hematogenous. Next, very important point, lymphatic spread is not seen. Lymphatic spread is not seen. What's the most common site of metastasis? The most common site of metastasis is the liver because of hematogenous spread. After that, how we are going to make the diagnosis? Can you see the tumor? Tumor is not having growth inside the lumen. So you can perform endoscopy, but you will not find any remnant of tumor. You might find evidence of hypervascularity at the site of tumor. You should not perform biopsy, endoscopic biopsy. Otherwise, tumor will rupture. So how we are going to make the diagnosis? Investigation of choice for diagnosis is the CCT. And be careful, endoscopic biopsy. It's contraindicated. Why? Because it can lead to tumor rupture. What's the treatment? See, this is the tumor. So just like sarcoma, I'm going to treat it. So what? I go for segmental resection or wedge-shaped excision with generally 1 to 2 centimeter margin. So I go for the treatment of choice is segmental resection or wedge-shaped excision. Wedge-shaped excision with 2 centimeter margin. Now the problem. In certain cases, the tumor is unresectable. Unresectable means the tumor is going to involve transverse colon, on the left side spleen or kidney. So left kidney, spleen or transverse colon is involved and this tumor is unresectable. So we have to downstage the tumor, and after downstaging the tumor, what? We have to treat it. So question is asked, what's the drug of choice for unresectable GIST? And it's the imatinib mesylate. Next question, what is the second line agent for unresectable GIST? Second line agent for unresectable GIST, and it's the sunitinib. And there is a new drug. Question, what's the third line agent for unresectable GIST? And it's a new drug. It's the regorafenib. Regorafenib. Question, suppose we start imatinib mesylate, how we respond the assessment or how we respond. Suppose we start imatinib, how we assess the response of therapy? We go for PET scan. And even after treatment, if there is recurrent GIST, what's the gold standard investigation? It's the PET-CT. So two statements. First, investigation of choice for assessment of response of imatinib, and that is PET scan. It's the PET scan. And the second question, gold standard investigation for recurrent GIST. Gold standard investigation for recurrent GIST, and that's PET-CT. That's PET-CT. So this is how we are going to manage the GIST. Question is asked about a triad. What's the name? It's the Carney's triad. So what are the components of Carney's triad? First, there is multifocal GIST. There is pulmonary chondroma. And there is extraadrenal paraganglioma. adrenal paraganglioma. So there is extra-adrenal paraganglioma. So these are the components of Carney's triad. Now see, what's the name of this condition? Can you see? There is hypertrophy of circular muscle fibers near pylorus, and this is known as what? Hypertrophic pyloric stenosis. So the name of this condition is congenital hypertrophic pyloric stenosis. But be careful, it is found to be acquired. So since it's acquired, can you see its name has been changed? So at the place of CHPS, now the name is IHPS. The full form is infantile. It's infantile hypertrophic infantile hypertrophic pyloric stenosis. First question, it's not congenital, it's acquired. What's the incidence? Incidence is the 1 in 3000 to 4000 live births. Here, firstborn males are most commonly affected. Now see here, child is normal at birth since it's acquired. So the child is normal. It's normal at birth. So question is asked, what's the age of presentation? So in this case, age of presentation, it's the 4th to 6th week after birth. 4th to 6th week after birth. What's the problem here? You can see, in this case you can make out that there is hypertrophy of circular muscle fibers at pylorus, and because of this there is obstruction. So what's the pathology? It is characterized by hypertrophy of circular muscle fibers. Where exactly? At pylorus. Because of this, what's going to happen? If there is hypertrophy, now see what happens after the breastfeeding. After breastfeeding, patient will be having multiple episodes of vomiting. So what are the clinical findings? Since there is obstruction, there are multiple episodes of vomiting. There will be peristalsis also, and this peristalsis starts from proximal part of stomach and it goes to the distal part. Second, when you perform the palpation, you are going to feel this mass. So this is felt as olive or mass. Now see the findings. Clinical features. There are multiple episodes of non-bilious. It can be projectile or non-projectile vomiting. Multiple episodes of non-bilious, projectile or non-projectile vomiting. Okay, now see, if we perform the examination, we can see what's the direction of peristalsis. It's from left to right. Can you see? From the proximal part of stomach to distal part. So direction from left to right. Second, this hypertrophied muscle is felt as a palpable mass or olive. So there is palpable mass or olive. This question was asked that where is the mass or olive? It's in epigastrium or in right hypochondrium. So it's palpable in, most commonly in epigastrium, sometimes in right hypochondrium. Simultaneously, there is direction of peristalsis. From left to right. So generally these kids are brought to pediatrics department, and one experienced clinician can easily make the diagnosis only on the basis of these findings. But what is the investigation of choice for diagnosis? The investigation of choice for diagnosis is the ultrasound. Nowadays, they are asking the diagnostic criteria for ultrasound. So see, what's the diagnostic criteria? First, this is the pyloric muscle thickness. It should be more than 4 mm. This is the channel length. It should be more than 16 mm. And this is the transverse diameter. It should be more than 13 mm. So, what's the diagnostic criteria? First, pyloric muscle thickness. Pyloric muscle thickness. It's more than 4 mm. Second, channel length. More than 16 mm. And third, transverse diameter. Transverse diameter. And this transverse diameter should be more than 13 mm. This is the diagnostic criteria. Investigation of choice for diagnosis is ultrasound. But be careful, diagnosis can be made. It can be made on barium meal. So what are the findings on barium meal? On barium meal, there is string sign, there is shoulder sign, string sign, shoulder sign, and double track sign. String sign, shoulder sign, double track sign. But generally diagnosis is made by ultrasound. Now comes the question, what kind of dyselectrolytemia occurs in infantile hypertrophic pyloric stenosis? See, it's very easy to understand. Can you see? This is the stomach. In the stomach there is HCl and there is mucus which contains potassium, and here is the hypertrophy of circular muscle fibers. Because of vomiting, all these electrolytes are lost. So patient will be having hypokalemia, hypochloremia, metabolic alkalosis. There is metabolic alkalosis. Why? Loss of proton or acid. In severe cases, what's the problem? In kidney, compensation occurs. What compensation? In kidney, especially in the collecting duct, there is sodium proton exchanger. So if there is sodium proton exchanger, there is loss of proton in vomitus. So kidney tries to preserve H+, and kidney starts excreting sodium. So kidney tries to preserve H+, starts excreting sodium. But what will happen? In severe cases, since there is loss of sodium in urine, sodium takes too much of water also. So there is loss of water, loss of sodium. So body goes in a state of hypovolemia and hyponatremia. In severe cases, when kidney is going to sense hypovolemia and hyponatremia, kidney is going to reverse this function. It starts preserving sodium and it starts excreting H+. Since it starts excreting H+, there is paradoxical aciduria. So what happens here? Apart from these three findings, there is paradoxical aciduria. But be careful, this paradoxical aciduria, it doesn't occur in all cases. It occurs only in severe cases. So the question is asked, what's the characteristic dyselectrolytemia? Is the hypokalemia, hypochloremia, metabolic alkalosis with paradoxical aciduria. It means it's a type of medical emergency. And since it's a type of medical emergency, what's the management? It's the IV fluids with correction of dyselectrolytemia. With correction of dyselectrolytemia. Simple. So question, what is the fluid of choice? The fluid of choice, and the fluid of choice, be careful, is the normal saline. The fluid of choice is normal saline. And what's the treatment of choice? It's the Ramstead Friedet pyloromyotomy. It's the Ramstead Friedet pyloromyotomy. This is the treatment of choice for infantile hypertrophic pyloric stenosis. Now we are going to discuss bezoars. What is bezoars? It's the collection of non-digestible material. So the bezoars are collection of non-digestible material. Questions are asked, what are the types of bezoars? So see the types. Overall most common is phytobezoar. It's having vegetable origin. So this is most common type overall. Second is trichobezoar. What is this trichobezoar? This is collection of hair, and this is the most common type in children. Trichobezoar is the most common type in children. Third is lactobezoar. What's the problem in lactobezoar? There is collection of milk concretions in stomach, especially in formula fed infants. So there is collection of milk concretions. So there is undigested milk concretions. And the fourth is pharmacobezoars. This is pharmacobezoar. There is collection of some large tablets in stomach. So these are four types. Overall most common is phytobezoar, and the most common type in children is trichobezoar. Most commonly asked questions are about trichobezoar. So we are going to discuss in detail trichobezoar. So in this case, what's the problem? There is concretion of hair. So in this case, there is concretion of hair. So obviously, it is common in the patients who are having long hair. So it's common in long-haired girls or females, girls or women. What is the problem with these girls or women? They have a psychiatric abnormality of trichophagy. Trichophagy means eating their own hair. So it's associated with trichophagy. There is a condition known as Rapunzel syndrome. What is Rapunzel syndrome? There is collection of hair, and these hair are so long that there is extension of this hair till duodenum. So what is Rapunzel syndrome? So what is this Rapunzel syndrome? So in this case, there is gastric trichobezoar. Gastric trichobezoar with extension into duodenum. Extension into duodenum. So here you can see this is this ball of hair collected into stomach, and its extension is up to duodenum. So this is Rapunzel syndrome. What is the problem in majority of cases? See, Suppose this is the stomach, and in this stomach there is collection of what? Hair ball. Because of this collection of hair ball, what will be the problem? There is ulceration because of the hair, and this leads to abdominal pain. Second, since this hair ball is causing obstruction, it can lead to what? Gastric outlet obstruction. So see the clinical features. In this case, there is abdominal pain. And what's the cause of this abdominal pain? It's ulceration caused by hair ball. And second, the patients are having gastric outlet obstruction. How we are going to treat? Most of the patients require surgery because it leads to obstruction. So what? We have to go for surgical removal. And second, since most of the patients are having psychiatric disorder, what? Trichophagy. So we have to provide what? Psychiatric care. Psychiatric care. So this is how we manage the trichobezoar. Next is gastric volvulus. So what is volvulus? Volvulus is torsion. So in this case, there is torsion of stomach. Now, it is of two types. One is organoaxial and second is mesenteroaxial. Organoaxial means along the longitudinal axis of organ. Which organ? Stomach. So it is of two types. First is organoaxial. This is most common type. It is responsible for 2/3 of cases. In organoaxial gastric volvulus, here torsion occurs along longitudinal axis of stomach. Be careful, along longitudinal axis of stomach. And the second is mesenteroaxial. Mesenteroaxial. Be careful, this is less common and it's responsible for 1/3 of cases. Here, torsion occurs along vertical axis. So torsion along vertical axis. Now see this picture and see which one is organoaxial and which one is mesenteroaxial. This is along the axis of stomach, longitudinal axis. So can you see this is what? This is the organoaxial and this is along the vertical axis. So this is what? Mesenteroaxial. Gastric volvulus is further divided into two types: primary gastric volvulus and secondary gastric volvulus. Generally, in primary gastric volvulus, there is some congenital abnormality without any diaphragmatic defect. But secondary gastric volvulus is secondary to some abnormality. And what's that? That's generally a defect in diaphragm. So have a look. It's of two types. First, primary gastric volvulus and second is secondary gastric volvulus. This primary gastric volvulus, it's associated with congenital asplenia or wandering spleen and generally in primary gastric volvulus, which volvulus is seen? It is associated with mesenteroaxial volvulus. This mesenteroaxial volvulus is partial, means it's less than 180 degree and it's recurrent. So see, it's partial means less than 180 degree and it's recurrent. And as I told you, this is a question. This is not associated with a diaphragmatic defect. So it's not associated with diaphragmatic defect. But see, this secondary gastric volvulus is secondary to diaphragmatic defect. So this occurs secondary to anatomical defect. And what's that anatomical defect? It's the diaphragmatic hernia. It's the diaphragmatic hernia. So generally it's the diaphragmatic hernia. I told you primary gastric volvulus is generally mesenteroaxial, but be careful, this one is organoaxial. Question is asked, what's the most common cause in children? So in children, it's the congenital diaphragmatic hernia. In esophagus, we discussed what's the most common congenital diaphragmatic hernia in children? It's the Bach-Dallek hernia. And what about adults? It's the paraesophageal hernia. It's a type of hiatus hernia. So these are the differences between primary gastric volvulus and secondary gastric volvulus. After that, there is difference in the presentation of organoaxial and mesenteroaxial gastric volvulus. See the difference? Clinical features. Generally, organoaxial volvulus, it presents acutely. So there is acute presentation. It presents acutely. And I told you it is associated with diaphragmatic defect. But what about this mesenteroaxial volvulus? I told you it's partial, means less than 180 degree, and it's recurrent. This is recurrent. And I told you it's not associated with diaphragmatic defect. One question which is most commonly asked about volvulus, gastric volvulus, and that's the triad. What's the name of triad? It's the Borchards triad. In gastric volvulus, there is a triad which is positive, Borchards triad. What are the components? There is epigastric pain, inability to vomit, inability to vomit, and inability to pass nasogastric tube. Inability to pass nasogastric tube. So what's the problem? Since there is torsion of stomach, because of torsion there is ischemia, and because of this ischemia there is epigastric pain. Since torsion occurs, patient cannot vomit, and whenever you are inserting the Ryle's tube, you cannot pass the Ryle's tube or nasogastric tube. How we can make the diagnosis? It can be diagnosed by barium studies or endoscopy. So see, diagnosis can be made by either barium studies or endoscopy. Now, management depends on the presentation and on the type. Generally, organoaxial volvulus presents acutely and it is associated with diaphragmatic defect. So what we have to perform first? Detorsion after laparotomy. So detorsion, and after performing detorsion, we have to repair the diaphragmatic defect. But mesenteroaxial is partial and recurrent. There is no diaphragmatic defect. So in that case, we have to perform the fixation of stomach, and that is gastropexy. So see, the treatment. In cases of acute volvulus, first we have to go for reduction of stomach, reduced, and then uncoiled. So stomach is, first we have to go for reduction of stomach. So stomach is reduced and then uncoiled, followed by repair of diaphragmatic defect. Repair of diaphragmatic defect. Simple. And if patient is having spontaneous volvulus, generally there is no diaphragmatic defect In these cases, we perform detorsion followed by fixation of stomach, that's gastropexy. Fixation of stomach, and that's gastropexy. So this is how we manage the volvulus. Now question is asked, what's the name of this condition? Can you see? This is known as teapot stomach. Teapot stomach. So question is asked, what is the cause of this teapot stomach? Can you see this is the stomach? Clear? So what's the cause of this teapot stomach? In this teapot stomach, which is also known as handbag stomach. In this case, because of ulceration, there is longitudinal shortening of lesser curvature. So it is characterized by longitudinal shortening of lesser curvature due to healing of gastric ulcer. Due to healing of gastric ulcer. So it looks like teapot or handbag. So that's why it's known as teapot stomach or handbag stomach. Now in this case, can you see what happens in this stomach? There is cicatricial contraction of the stomach because of healing of a saddle ulcer. And that's why, can you see what's the appearance? This is the appearance. Clear? And it looks like what? It looks like this, hourglass. So this is known as what? Hourglass stomach. So what's the name of this condition? This is known as hourglass stomach. So this is hourglass stomach. So what's the cause of this hourglass stomach? It's caused by cicatricial. It's caused by, there is cicatricial contraction. Here you can see cicatricial contraction of a saddle shaped ulcer at lesser curvature. Saddle shaped ulcer at lesser curvature. So these are two one-liner questions. One is teapot stomach and one is hourglass stomach, which is frequently asked in exam.